Good afternoon, ladies. This is Dr. Linda Hughes from Unique Interventional Radiology. Very happy that you're able to join us for this free webinar this afternoon. We're going to tell you everything that you need to know about uterine fibroids in terms of what they are and what your treatment options are. So hopefully this will be an educational afternoon for you. My name, as I told you, is Dr. Linda Hughes. I am a vascular and interventional radiologist, and I am certified by the American Board of Radiology, and I am one of the directors of Unique Interventional Radiology. I'm originally from Boston, but I've been in the South Florida area for more than 20 years, working in South Florida, taking care of our patients. So I think a good question for us to start with is, what exactly is an interventional radiologist? I think most people are familiar with the term radiology in terms of a physician who reads imaging such as x-rays and CAT scans and MRIs, but there are actually several different specialties in radiology. An interventional radiologist, like myself, is somebody who's a board-certified physician, and that we're trained in both radiology to be able to read and interpret films, but we're also trained in performing minimally invasive therapies, and that we use imaging, whether it's ultrasound or x-ray or CAT scan, to guide us for these therapies so that they can be minimally invasive. And in addition to the fibroid treatments that we're going to talk about today, we also deliver many minimally invasive treatments for a variety of conditions, including cancer and kidney disease, amongst others. As we had mentioned earlier in the talk, we're going to explain exactly what is a fibroid, what are the symptoms of fibroids, what are the different treatment options that exist today, and I want to spend the most time talking about Uterine Fibroid Embolization, or UFE. Exactly what is it, how is it performed, and what are the benefits of this UFE over surgery such as hysterectomy or myomectomy? What is the effectiveness of it? So hopefully this is going to be an enlightening afternoon for you. So what are uterine fibroids? Basically, they are non-cancerous growths in the female uterus. I'll show you a diagram coming up, but basically, in order to understand what your treatment options are, I think it's important to understand the anatomy and what you're potentially treating. So the female uterus sits in the middle of the pelvis. You have your bladder in front, you have your rectum in back, and then the uterus has two components. There's a lining or a cavity inside, and then there's the wall, which is made out of smooth muscle. And fibroids are smooth muscle tumors. They're growths that occur inside the wall. There are more than 200,000 cases that are diagnosed every year in the United States, but many of these women don't have symptoms. So if you don't have symptoms, you don't need to be treated because they're not cancer and they're not precancerous. However, when women do have symptoms, these women, such as yourself, possibly, are entitled to treatment. And I think it's important to understand in this day and age what the treatment options are. Hysterectomy was the most common treatment for decades, but in the 21st century, there are certainly less invasive options for you to consider. This is a quote which is interesting in terms of the demographics of fibroids, saying that Black people develop fibroids at earlier ages than white people, and that the tumors are often larger and more intrusive. Also more likely to have the fibroid surgically removed, with a higher rate of hospitalization due to fibroids. So typically, I've taken care of women as young as 19 and as old as 69 with symptoms from fibroids, but the vast majority of women tend to be between the ages of 30 and 55. And they tend to be more common in Black women and of Caribbean descent. So literature says that typically 1 out of 3 women over 35 can have fibroids, but in the Black population, it's 1 out of 2. Now, if we look at this diagram, it goes back to what I was talking about a few minutes ago in terms of understanding the anatomy. So in terms of looking at the uterus, the vagina is contiguous with the cervix, and then the cervix is the lower part of the uterus.
Go ahead.
So again, looking at this diagram, we see that the uterus has a cavity or a lining inside, and that it is lined with what is called the endometrium. And what happens every month with the changes in hormones, that lining gets thicker, we anticipate a pregnancy, we don't get pregnant, you slough it off, and that's your period. The wall here, the smooth muscle wall, is where the fibroids typically grow. Most of them are what we call intramural, which is in the wall, but some of them can be submucosal, which is kind of pooching into the cavity. Some of them can be pedunculated on a stalk like a lollipop or a mushroom. So it's important for us, as we think about treatment options, to have a handle on where these things are located, how big they are, and what shape they are. Now, before we move on to the next slide, we have a diagram here, but to the right, this is actually an MRI. And the MRI shows us a very, very clear picture. Ultrasound is a very helpful screening tool, but if we're interested in the treatment option UFE, an MRI is exquisite in the terms of the detail that we see with regard to the size, the number, the location, and the vascularity of these fibroids. So it really helps us to determine if somebody's a safe and appropriate candidate. This MRI shows you the white line that you see in the middle. On this top one, actually on both slides, is the endometrial cavity or the lining. And then the gray that you see is the wall of the uterus. And wherever you see a black circle or a black ball is actually a fibroid. So this top slide, this woman has a number of fibroids in the wall. The bottom slide, the woman has several that you can see here in this front wall, as well as a big one here on the top of the uterus. Also notice the relation to the bladder. So this white thing that we're seeing in front is the bladder, and you can see, as we'll get into, why a lot of women have urinary symptoms, because the fibroids, as they enlarge, can press on the bladder, and there isn't room for the bladder to expand. So what are the symptoms of uterine fibroids? As I mentioned, that there are a number of women who are asymptomatic and don't have any problems, but as we had mentioned, is 1 out of 3 women can have symptoms, and they can be very significant. Some women have multiple symptoms, some women just have one symptom, and all you need is one symptom for it to be annoying enough or a health issue that you're entitled to treatment. So with this fibroid or fibroids, if you have multiple, it's a mass. They take up space. Like I said, they can be single, they can be multiple, but the fact that they're small or big, depending on where they're located, they can push on your rectum, they can push on your back, giving you low back pain. They can tickle some of the nerves in the pelvis and give you thigh pain, as well as I mentioned, the urinary symptoms. Bleeding is a very, very common symptom. Heavy bleeding, prolonged bleeding, periods are lasting longer, passing blood clots, and with this heavy bleeding, also a lot of women are anemic. Some women have needed blood transfusions, iron transfusions. I've had patients who've said that they've passed out driving or walking up a flight of stairs because the bleeding has been so bad that they've become anemic. So this is something that you want to try and address before you're at the stage of anemia. Infertility, which we'll speak about at the end of the webinar, but fibroids can cause infertility. That if these fibroids are in the uterus and they're big and bulky and they're taking up space, there either isn't room for, number one, to get pregnant, but more often is there isn't room for the pregnancy to grow, and that a lot of women end up having miscarriages or premature deliveries because of the fibroids. Another symptom is pelvic pain, whether it's severe cramping with periods. There are some women who have pain and cramping throughout their entire month. As I mentioned earlier too, depending on where these fibroids are sitting, they can cause thigh pain, they can cause back pain. Women can have problems with constipation, but also a lot of women, as I mentioned, can have urinary symptoms, having to void a lot, as well as nocturia, which is waking up at night to pee or to urinate because the bladder can't fill up to its normal capacity because these fibroids are squishing the bladder. Another symptom, which I didn't mention on the slide, is a medical term called dyspareunia, which is pain with intercourse. A lot of women have very painful intercourse because the fibroids are sitting in such a location that it can be extremely uncomfortable. So what are our options? And I think the nice thing in 2020 is that we have options. And I think that knowing the anatomy helps you decide what the options are. So surgical options include hysterectomy, which is surgically removing the uterus. Myomectomy is surgically removing the fibroids, but leaving the uterus for the purposes of getting pregnant in the future. The myomectomy and hysterectomy both involve surgical incision, whether it's laparoscopic or Da Vinci or an open surgery. It's also general anesthesia, and the recovery times can take several weeks to up to several months. The myomectomy was more popular before embolization came along, which I'll get into later. Myomectomy rates are decreasing because, unfortunately, it is a Band-Aid that about a third of women that have a myomectomy, the fibroids do come back. So in the olden days, if women hadn't had their children yet, the obstetrician gynecologist would tell patients, let me do a myomectomy, I'll remove the fibroids, and when they come back and after you've had your babies, we'll do the hysterectomy. But things have changed nowadays, that there are other options. Your non-surgical options include the least invasive would be medical management with hormones. What little we know about fibroids is that they can get bigger with pregnancy, they can get smaller with menopause, and different combinations of hormones can help with these symptoms. But the problem is it's a Band-Aid. It doesn't actually treat the fibroids. It's just a Band-Aid to help mask some of the symptoms. But in some women, that may be all that needs to be done. Another treatment is something called an endometrial ablation, which is a procedure that the GYN does in the office, where they will place a little catheter that has a balloon on the end of it, go through the vagina, through the cervix, and place it inside the cavity, and either use a hot oil or hot water to burn the lining. So if your problem is in the lining, a hyperplasia, which is a benign thickening, little polyps, or even if you have little fibroids that are bulging into the cavity, the endometrial ablation can be a good treatment. But for most women, if the fibroids are big and bulky and they're in the wall of the uterus, the ablation isn't going to accomplish what needs to be done. Another option out there, which I think for the sake of being aware of what's out there, is something called HIFU. But for the most part, this is not something that I would recommend for women with fibroids. Basically, HIFU is high-frequency ultrasound. Most people are familiar with ultrasound for imaging, whether it's a breast ultrasound, a pelvic ultrasound, an echo for the heart, or for the carotid arteries, and that is a low-frequency sound wave that generates a picture. HIFU, or the high frequency, is used. You probably may have heard of people who have kidney stones and having lithotripsy or having their stones blasted. Certain men with prostate tumors, the HIFU has been effective for treating prostate tumors, certain tumors in the liver. And there's been some research for over 20 years using MRI to localize what the fibroids are and using this high frequency probe to burn the fibroid tissue. In theory, it sounds great, but the reality is, with almost 20 years of research, is the data isn't very good, that oftentimes if you have multiple fibroids, the probe can't penetrate deep enough to the back wall, if bladder's in the way, if bowel's in the way, if the patient is a little heavy and can't penetrate through the abdominal wall. And the data hasn't been very encouraging to the point where my society, as well as the American College of OBGYNs, do not support this as a standalone treatment for fibroids, and that insurance companies are not paying for this. It's a cash procedure because the data hasn't been very good. But again, you're welcome to look into it, to Google it, and to learn some more information if you'd like. Uterine Fibroid Embolization is what I'd want to spend the most time talking about, or UFE. So let's see what I can try and share with you gals this afternoon. So, as I mentioned earlier, that there are quite a few hysterectomies that are done in the country every year. That some research says that there's over 500,000 hysterectomies done in this country every year, and that about a third of them are done for fibroids. I think the frustrating fact, though, is that more than 40% of women undergoing a hysterectomy didn't realize or don't realize that there are less invasive options. So I think it's important for you, if you're somebody with fibroids, to do your homework and your due diligence and to know what your options are before you make a decision. So what is this UFE that I keep talking about? And basically, just in terms of some background, embolization is the medical term for putting something into the circulation to cut off the blood flow. It's been around for over 100 years, and we as interventional radiologists literally do it from head to toe. If somebody has an aneurysm in their brain that's bleeding, we embolize it. There are certain tumors, brain tumors, kidney tumors, that the surgeons will ask us to embolize to cut the blood flow off before they operate to minimize bleeding. People, if they have nosebleeds and the ENT can't control it with packing or cautery or balloons, we can embolize the arteries that are causing the nosebleed. Trauma. if somebody's had a gunshot or a stabbing or a car accident or anything that causes internal bleeding, diverticulitis, if there's bleeding and the surgeon can't control it, we're able to go in and embolize it and to control the bleeding. Women who bleed after they have a baby, it's not unusual for the obstetrician to ask the interventional radiologist to embolize the uterine arteries to help control the bleeding if there's a problem with the placenta or bleeding with the delivery. The whole way it came about for fibroids is the fibroids are very vascular, they have a very rich blood supply, and they end up parasitizing or stealing the blood flow from the uterine arteries, and it's sort of a chicken and the egg. The more blood flow, the bigger the fibroids, the more blood flow. And there were certain gynecologists over the years who used to ask us to embolize the uterine arteries before they did a myomectomy or a hysterectomy to minimize bleeding at the time of surgery. And there was a physician in Paris over 20 years ago who noticed the time frame between the women having the embolization and the women going on to surgery. Most of the women were getting better before the surgery. So it was enough to kind of prompt us and to goose us to do some research. And lo and behold, 20 years later, we have a good database on this UFE being an effective standalone treatment for fibroids. And basically what it involves is introducing a very thin catheter, which is like IV tubing, into the artery feeding the fibroids, and that we inject either PVA, which is a plastic particle, or most of us tend to use gelatin particles. And what the gelatin particle does is it cuts the blood flow off. So short term, it cuts the blood flow off. And long term, even though it's gelatin, it's very irritating to the lining of the blood vessel. So it causes that blood vessel to shut down permanently so that it can't open back up again in the future to feed the fibroids and for the symptoms to come back. So it's a permanent embolic, which is what we want. And this procedure is typically done under a twilight sedation. So it's a very light, comfortable sedation. So this schematic here on the left is basically a cartoon showing what we see when we actually do the procedure. So as I mentioned, it's done under a twilight sedation, so patients are extremely comfortable. It's a combination of Versed to make patients sleepy and fentanyl for pain control. And what we do is we place the catheter, or the tubing, into the artery, the blood supply feeding the fibroid. And the beauty of this procedure is it doesn't matter whether you've got 1 or 101 fibroids, that by embolizing both the right and the left uterine arteries, we're able to cut the blood flow off to all of the fibroid tissue. Once in a blue moon, and it's extremely unusual, but once in a while you can have a little bit of flow coming off of the ovarian artery, and that's a special circumstance, and that can be embolized if we need to. But the vast majority of women, embolizing the uterine arteries is sufficient for us to be able to control the fibroid symptoms. So by injecting these particles, as I mentioned, they're going to get lodged in the blood vessels that are feeding the fibroid tissue. And on the right is an example of what we see. As I mentioned, we do this under X-ray, so it's a roadmap, and we're able to define the anatomy and for us to be able to precisely place these beads exactly where they need to be, so that it's a safe embolization, that we're embolizing the fibroids, but we're not embolizing the normal uterine tissue or anything else in the area. These are some examples, and again, you're not interventional radiologists, but I think sometimes a picture's worth 1,000 words. If you look at the first slide on the left that says PreEmbolization, basically normal blood vessels have a very predictable branching pattern. If you look on the right here, these are actually some of the branches going to the buttocks and the gluteal muscles, and very straight, predictable branching pattern. When you develop fibroids, normally a uterine artery should be a teeny tiny artery that you can barely see when we take these pictures. But with the fibroids, the blood supply gets bigger, and you can see sort of this lacy, sort of reticular, disorganized pattern that you see in the middle of the pelvis. And this basically is the abnormal blood supply to the fibroid tissue. So again, what we say is under X-ray, we're able to put our catheters in, and there are different shapes, and we have wires that we can reach just about any point from head to toe. And basically, once we confirm that we're in a safe spot, we inject the gelatin beads, and then your post-embolization picture, you can see beforehand how lacy and all of that abnormal blood supply. The last picture here on the right, post-embolization, you can see how nice and clean that what we're looking at is the normal blood vessels in the pelvis, but we've shut down all of that abnormal blood supply to the fibroid tissue. So how effective is a UFE? As I mentioned, the first case actually was done in 1995 in Paris, specifically for treating fibroids. and that we have had excellent results reported worldwide. I have done over 1,000 embolizations myself. I believe at the last meeting I had been to, we have data between Canada and the United States on over 300,000 embolizations that have been done, and we have excellent data in somebody who is an appropriate candidate, who understands what our endpoint is and what our definition of success is, as well as it is performed by somebody who is a trained interventional radiologist with experience with embolization. So it really is a great minimally invasive option. And this works for 3 reasons. Basically, you reduce the blood flow. You cut the blood flow off, you're going to control the bleeding. So the blood clot should go away, the heavy bleeding, the prolonged bleeding should go away, but the woman should still have a monthly menstrual cycle, and it should be a lot lighter. If women are anemic, the anemia should correct itself. By cutting off the blood flow, the fibroids shrink, and that no new ones should grow. And I usually tell women that just as important as the shrinkage, and this is extremely important, is that the fibroids get softer. So unlike surgery where you go in, you cut it out, they're gone, with the embolization, they're still going to be there, but they're going to be devascularized, they're smaller, and they're going to scar and retract into the wall of the uterus. But as well as them scarring, is they also get softer. So if you were to talk to a pathologist with a hysterectomy specimen, if they get a fibroid, they say it's like a firm rubber ball. It's a firm mass. They say back in the day where they used to get a specimen after an embolization and a hysterectomy, they say by imaging you may see that there's still a blob in there, but when they have the specimen, they say it's more like a little scoop of oatmeal. So the fact that it's softer, it's smaller, and you cut the blood flow off, that combination of things gives women the relief that they're looking for. Because typically as a patient, you're not coming in to see the doctor because you've got a 7.8 centimeter anterior fundal fibroid. You're coming in because you've got pain, you've got bleeding, you're peeing a lot. So if we can alleviate those symptoms and make you feel better, that's our endpoint for success. Before we get into the statistics in terms of success, these are some more MRI pictures, which again are valuable. On the left, you can see this is a gal with multiple fibroids before the embolization. On the right-hand side, you can see this is 3 months after the embolization. You can see the uterus is smaller, there are fewer fibroids, and the fibroids that are there are smaller. This is another example of a gal 6 months later, and you can see that that main fibroid at the top of the uterus has basically shrunk away to almost nothing. The uterus itself is smaller, and you can see that it's not pressing on the bladder the way it was before the embolization procedure. So in terms of our results, technically in terms of doing the actual procedure, that most of us that have experience and with patients with having appropriate favorable anatomy, everybody is over 95%. Most of us are closer to 98 to 99%. And the nice thing is, I guess, devil's advocate, if you're part of that 1 to 3% of patients that you don't get relief, we haven't burned a bridge. You can still try hormones, you can still do a myomectomy, you can still have a hysterectomy, you can still do a HIFU, you could still try any other experimental protocols or research trials that may be out there. But typically, we offer this to patients if we think based on the physical exam, your symptoms, and the imaging, you're going to have success from the treatment. Again, in terms of the clinical success, again, it varies. Everybody is over 80%. Most women are over the 90 to 95% success rate. And there can be some other confounding factors in terms of it not being 100%, whether it's some flow coming off the ovary. Some women can have something called adenomyosis, as well as the fibroids, that if women are interested and want to come in for a consult, we can delve a little bit more into that. That is a term that's similar to endometriosis. It occurs in the uterus, but a lot of the symptoms mimic fibroids, and the treatment can be the same. The reduction in the size of the uterus and the fibroids, I'm quoting you here about 50%, but it could be as little as 30%. It could be as much as 90%. Different fibroids within a woman can shrink different amounts. But as I've said, and you can see on the bottom of the slide, that you're not coming in because of a certain size fibroid, you're coming in because you have symptoms. And if we can make those symptoms go away and you're happy, quality of life, you're feeling better, you're not anemic, you're not cramping, your urinary symptoms are resolved, that is our definition for success. Now, with any procedure, there are obviously your risks at complications as well as your benefits and your success. Complications are few and far between, which again, if you're interested and you come in for a consult, we can delve a little bit more into it. But basically few and far between, in that, as all of you gals know, anytime you touch a patient, regardless of whether it's a cesarean section, a root canal, a breast job, a tummy tuck, gallbladder being taken out, anytime you touch a patient, there's always a risk of infection. There have been some reports of infection requiring hysterectomy. Most of that is predominantly the European data, where they don't give antibiotics when they embolize. For all of us here in the United States, we give an IV dose of an antibiotic during the procedure, and then women usually go home on a few days of an oral dose, again, to prevent infection. And I've taken care of some sick ladies, including HIV, AIDS, diabetic, liver transplants, kidney transplants. We've had some very sick women, and that infection is virtually non-existent. So in theory, touching you, risk of infection. Second thing to be aware of is that there is about a 1 to 2% chance of going into menopause in the procedure. Now, a 98 to 99% chance that it's not going to happen. If it does happen, it's not going to cause cancer, infection, gangrene. You don't have to have your ovaries taken out. It's just if you do go into menopause and have symptoms, we have to work with your gynecologist about whether or not to do a hormone replacement. Now, for me, in over 1,000 patients I've taken care of, I think my menopause rate is about 0.5%, and that all of the women were in their mid-50s, and they were already starting to go through the change. So I think menopause is, in theory, a complication, but it's a very, very low risk of that happening. A couple of other very rare complications that could happen, and again, if any of you gals or ladies are interested, when you come in for the consult, we certainly can go into more detail. But overall, an extremely safe and effective procedure. So the next thing that we should discuss is, what is the recovery period after a UFE? As we mentioned earlier in the webinar, this typically is done as an outpatient procedure. The procedure itself takes about an hour from start to finish, although you'll end up spending the entire day with us in the center for us to be able to observe you for several hours afterwards to make sure that when you do go home that you're comfortable, we have good pain control, you're able to tolerate food and drink, and we have a good level of analgesia. The procedure, as I mentioned, is done with a twilight sedation, so that wears out very quickly. And when we finish, there is a tiny little incision that we make in the right groin that is about the size of my pinky fingernail. That it is a dressing that we put on. There's a small closure device that we use, which we can go into detail when you come in for the procedure. And that basically dissolves over several weeks, so there's nothing permanent left in the groin. No stitches, staples, or anything left permanently in the groin. In terms of the recovery, I usually ask women to take 1 to 2 weeks off from work. I've had some women that have gone back to work in 3 days. I've had other women that have needed the full 2 weeks. It all depends on how extensive the embolization is, and everyone is different in terms of their pain threshold and how they tolerate procedures and cramping discomfort afterwards. But that being said, typically by day 7 to 8, most women are back to their normal routine and their normal schedule. What the recovery time is, basically, is that you're crampy and bloated after the procedure. First few days, it feels like it's a bad period in terms of the cramping, and that we are able to control that with the prescription dose of ibuprofen. And for women who have an allergy or stomach issues and can't take ibuprofen, we have other medications that we can use to help control the cramping. Also send women home with a dose of an antibiotic for several days. We give an antibiotic intravenously as well. I have the philosophy that I would rather prevent one than treat one. And also a prescription for some Percocet for any breakthrough cramping if the ibuprofen isn't enough for the first several days. As I tell women, that typically what ends up happening, as we mentioned earlier, is that the fibroids are going to shrink after we cut the blood flow off. And when the fibroids shrink is when you have relief in terms of the symptoms with the bleeding, with the cramping, with some of the bulk symptoms in terms of the bloating and the urinary symptoms. Typically, 90% of women within the first menstrual cycle will notice a difference, that their symptoms are dramatically better. The other 10%, it can take up to 2 to 3 cycles for it to kick in. And I usually ask women not to be discouraged. For example, if we were to do the procedure several days before the onset of a menstrual cycle, it's not unusual for women to have a heavy period passing clots to basically shed the lining and hope that the next month that symptoms will be better. So typically most women the first month will notice a difference. If not, usually by month 3, everyone notices a big difference. And even though women will feel better within the first 3 months, the fibroids continue to shrink for up to 10 to 12 months after the procedure. We see the most shrinkage within the first 6 months, but usually at 10 to 12 months is when the maximum shrinkage is accomplished. And usually at that time, we'll ask to do a follow-up baseline MRI or minimally an ultrasound to be able to compare the pre and post imaging. So we've spent quite a bit of this webinar talking about the procedure itself, who's a candidate, who's not a candidate, what are the benefits, and just to sort of reiterate that this is a very safe procedure. If it's done in the hands of somebody who has experience with embolizing, it's a very safe procedure. The recovery time is considerably shorter than surgery, which can be 6 to up to 8 weeks recovery time, as well as healing a surgical incision. You are saving your uterus by not having the surgery that in theory maintains the ability for future fertility. It certainly is much less invasive, as we've talked about. From an insurance standpoint, most insurance companies are paying for this, including Medicare and Medicaid. I can't think of the last time we had an insurance company who declined authorization for this procedure because we've had such good results. And they like the fact that it's certainly much less expensive than the surgical procedure, the surgical option. And as we mentioned earlier, we're talking 1 to 2% chance of menopause. So overall, a very, very safe procedure. In terms of the indications, again, as we talked about earlier, there's a host of symptoms and problems that women can have, from heavy bleeding and passing blood clots and issues with anemia to cramping that's really bad during the menstrual cycle. Some women have cramping and pain the entire cycle, the abdominal bloating, urinary symptoms, discomfort or pain with intercourse. But there are a number of indications, and that typically women, and you're referring gynecologists and us as interventional radiologists, will consider the UFE procedure if conservative treatment hasn't worked, if women are really suffering with severe symptoms, and that they would like a non-surgical option, a minimally invasive treatment. Now, in terms of the contraindications and the reason why we shouldn't do it or shouldn't offer it to an individual, they are few and far between, but there are certain contraindications that would stop us from doing the embolization procedure. We use X-ray dye for us to be able to obtain the roadmap and to inject the gelatin beads under X-ray. And if somebody has a severe allergy to the iodine contrast of the X-ray dye, that would potentially be a contraindication. There are some patients who have a mild reaction in terms of a rash or hives, and we can use a special dye and can pre-medicate patients, but if there's a serious life-threatening allergy to the dye, that would not be a safe patient for us to do this procedure. Women who have kidney disease, again, we have to use X-ray dye. In somebody who has healthy kidneys, the X-ray dye is not a problem. It gets excreted through the kidneys and in the urine, but if somebody has kidney problems, the dye potentially could make the kidney function worse. So that would be a one-on-one thing that we would work with the patients. If somebody has advanced kidney disease and they're already on dialysis, the dye is washed up with the dialysis, so that's not an issue. The location of the fibroids is important as well, not so much the size, but the location. As we had said earlier, that most of these are what we call intramural, which is in the wall. But some of them can be pedunculated on a stalk. They can be like a little lollipop, or they can be like a mushroom where they have a broad base. So a pedunculated fibroid, depending on the location and how thin the stalk is, potentially could be a contraindication, as well as what we call submucosal fibroids, which are those that have a component that can be sticking into the cavity. If it's a small amount or a tiny part of the fibroid that's submucosal, that's not a contraindication. But if there's a large fibroid that is submucosal that essentially is sitting in the cavity, that potentially is a contraindication. We technically can embolize it, but women aren't going to get the relief that they're looking for. They'll end up having a lot of contractions and pain with having a necrotic fibroid that's sort of slept into the cavity, because the ones that are on the wall are the safe ones to treat because they scar and shrink and retract into the wall. And then pregnancy, obviously if somebody's actively pregnant, that's an obvious contraindication to doing the procedure. But future fertility is something that if a woman is interested, we work closely with the OB-gynecologist to see if this would be something that would be useful to offer women to try and shrink and soften up the fibroids to increase the likelihood of fertility and a successful pregnancy. So as I had just described with pregnancy, depending on the studies you read, typically over the years, or before embolization was as popular as it is, myomectomy was the gold standard for women who had fibroids and hadn't had their children yet, is that the gynecologist would do a myomectomy to remove the fibroids. Women would have their children, and then if the fibroids grew back, the treatment at that time was then a hysterectomy. With embolization having come along, there are fewer myomectomies being performed with more embolizations being performed. So fertility after myomectomy, as I said, depending on the studies you read, it's variable just in terms of scar tissue. The same thing with embolization, but pregnancy after an embolization has been reported, but we can't guarantee it. And we don't have much data on pregnancy after an embolization because the vast majority of women that we treat either have had their children and aren't interested in future fertility or don't want to have children. But that being said, we do have one study a fellow named Jim Spees out of Georgetown had done probably about 15 years ago, and probably is the best study that we have out there, comparing 50 women who had fibroids who had a myomectomy, 50 women who had fibroids who had an embolization, and 50 women who didn't have fibroids or any fibroid treatment. They were the control population. And they looked at different factors such as miscarriage, placental problems, birth defects being the three most important, and that there was no statistically significant difference in the myomectomy population and the fibroid population compared with the general population. Now, did they happen? Yes, but it was no higher than the general population, so we certainly found that encouraging. But I think can't emphasize or stress enough that us as the IR, the interventional radiologist, if we do have a woman who's considering future fertility, that it is important for us to work very closely with the OBGYN so that we all have a common goal and do what's best for the patient. So I think in terms of wrapping up this webinar session this afternoon, I've been delighted that as many of you have signed up for this free webinar this afternoon, and hope that you did find this a helpful, useful webinar and did learn some good information. Our team, as you can see, we've got a team that includes secretaries, nurses who are all critical care trained nurses that have extensive experience, as well as our interventional technologists are all board certified as not only X-ray technologists, but they also have the extra training and experience as interventional. And as mentioned with myself, in terms of the physicians, that we are board certified, that we are fellowship trained, and that this is something that we do full time. If you're interested in coming in for a consultation, when you come in that day, we'd love to show you around. We have a beautiful outpatient center in Broward County. We have 5 private patient bays. We have 2 procedure rooms. We have state-of-the-art equipment. that we take pride in the fact that some of our health grades and Google reviews and patient feedback to some of our referring doctors in town have commented on how clean the place is, how bright and cheerful the place is, and that they've had a good experience with our trained and educated staff. We have a number of testimonials that patients have been kind enough to either do reviews, as I said, on health grades or Google or on our website. Certainly we have a few that we've posted here, but I think just as importantly is if somebody is considering this procedure and you do want to meet with me for a consultation, I also have a number of patients who have had the procedure and would be happy to speak with you as well one-on-one in terms of their experience as a patient. So I think that has given some patients comfort as well to not only speak with me and my staff, but to speak with the patient who has been through the experience. So as we close up this webinar, I think if you are a woman out there who's been suffering with fibroids and you're having symptoms and you're confused about what to do and what your options are and what are the advantages, what are the disadvantages, what are the complications, what are the risks, what are the benefits, I would urge you to book a consultation with Monica. Right now on our chat line, you've got a couple of options that you can do that with Monica. You can go online with our website address here. Certainly you can call our 786 number to schedule an appointment or send a text message. And in this day and age with COVID and restrictions and people's comfort level, I'm happy to meet with patients in our office, and that we are very particular and careful about screening patients when they come in, taking temperatures, getting an accurate history, and that we're minimizing the amount of traffic that we have here in our center. But there are some folks, some patients who feel more comfortable doing it over the phone, so we certainly can set up a telemedicine consult if that would make you more comfortable as well. So again, hope this has been helpful. And if any of you ladies out there are struggling with this and want some more information, I would suggest book the consult. Let's talk specifics in terms of what you have going on. So thank you for your time.
All right, everyone. Thank you so much for participating. If you haven't been engaged in the chat with Monica, please feel free to call the number. She'll definitely be able to set up an appointment, a consultation. She'll be able to answer also some high-level questions. But we understand this is a treatment that is definitely worth looking into if you haven't already. We're here to help, so we appreciate you guys attending and participating, and thanks so much. So I'm going to leave it open for the next 10 minutes in case you have any additional questions or in case you want to schedule a consultation. The chat will remain